Good morning, everyone. Welcome to this joint hearing for the first two bills. Joint hearing of the committees on health and House Committee on Human Services and Homelessness. My name is Greg Takayama. I chair the Committee on Health, and Representative Lisa Martin chairs the Committee on Human Services and Homelessness. Okay, we're getting off to a smooth start. We are, for the record, we are here in room 329 of the State Capitol, and it is Wednesday, February 4th at 9:01 a.m. Just to get your bearings and a couple housekeeping reminders for those of you who haven't been here before. You'll notice, first of all, if you've been here before, that we have no mics. The microphones are actually in the green lighted devices in the ceiling. And so when you do testify, we do ask you to speak from the podium, because even though we can all hear you, for purposes of YouTube, which is the hearing is being televised on YouTube live as we speak. So it gives you a better shot of you as you speak. And for those on Zoom, those testifiers, we ask that you keep yourselves muted and that you not have any, you not display any trademark items, because as I mentioned, we'll be on YouTube. Finally, we'll ask all testifiers to adhere to a 2-minute time limit, and we'll have a gentle ding from our committee people as a reminder. But we have a long agenda this morning, so we want to be sure and get through it all and be able to hear from all of you. So with that, let's begin with the first measure on our agenda, which is House Bill 1969, and it provides state funding for colorectal screenings. So first up, we have, let's see, Ryan Yamane on Zoom. Or you're not Ryan Yamane.
In person, even better.
Even better. Thank you.
Aloha, Chair, Vice Chairs, members of the committee. I'm Meredith Nichols, speaking on behalf of Department of Human Services, and we stand on our written testimony, and I'm here for any questions if you have them.
Okay, before you leave,
Yep.
I'm going to do something that some other chairs do and ask that you, instead of simply standing on your testimony, give a brief sentence or two as to where you stand on it.
I'm happy
for the benefit of the audience who don't have your written testimony.
That's yeah, very good. So we absolutely at the Department of Human Services appreciate the value of screenings for colorectal cancer. It's really important to catch it early on. We understand that as people may lose insurance, things like screenings become really difficult. They're out of reach financially. So we appreciate what the bill is trying to do, and then we also recognize that DHS MedQuest program doesn't have anything set up to run a program like this right now. We would have to invest in a program manager, somebody who could pre-screen claims, and do the administrative work that would be involved in making sure a program like this could work. But we absolutely understand and appreciate the importance of this type of screening.
Thank you very much.
Mahalo.
Let's see, we have Department of Health offering comments.
Good morning, Chair Takayama and Chair Martin and members of the committees. I'm Lola Irvin representing Department of Health. The Department of Health offers comments, and in terms of a short introduction to the issue, we know that 42% of people who are of eligible age, that's 45 to 75 years of age, have not been screened for colorectal cancer. The Department of Health is also concerned that those aged 45 to 54 years of age, so if you fall in that bracket, we are speaking to you, only 45% of the people in Hawaii have been screened. And so we are working on an educational campaign called I Got Screened to help people understand that it's for all of us and it can help prevent cancer. So age 50 and younger are now, colorectal cancer is the highest leading cause of death for those age 50. And so we offer comments and we do defer to the Department of Human Services. Thank you.
Okay, thank you very much. Insurance Commissioner Scott Psyche. Here, I know you're not Scott Psyche. Thank you.
Good morning, Chair, and Vice Chair, members of the committee. I'm Justin Chu. I'm with DCCA's Insurance Division, and you have our testimony providing comments. Our comments surround the reference to the FAQs, the frequently asked questions. So our concern is that the FAQs are sub-regulatory, so they're not actually law. They're guidance provided by the administration, and they can change over time. Sometimes they can go forward, sometimes they can go back. So by not having a specific reference, the mandate of state law, what state law needs to cover, can change over time based on, the guidance of the federal government. And similarly, because it's not a federal law, it could be subject to ACA deferral, which means that the additional cost to individual plans on the marketplace could be borne by the state.
Real quick before you
Sure.
So if we remove the FAQs from the language, would we be okay with just the U.S. Preventive Services Task Force language, which prescribes what?
I believe the USPSTF task force language is already in the statute.
Okay,
Yeah.
thank you.
Thank you.
Sorry. One thing I learned is if you write notes when you're wearing reading glasses, it's hard to read without reading glasses on. Let's see, Hawaii Primary Care Association? No, offering support. Cynthia Au, American Cancer Society.
Good morning, chairs, vice chairs, and joint committee members. Cynthia Au on behalf of the American Cancer Society Cancer Action Network, or ACS-CAN, testifying in strong support for House Bill 1969, which establishes a dedicated public funding assistance program for colorectal cancer screening for uninsured and underinsured Hawaii residents. The bill addresses a critical gap in preventive care. Cost remains one of the most significant barriers for individuals without insurance. Without insurance coverage, people are far less likely to receive routine preventive services, including life-saving colorectal cancer screening. As a result, they often forego unscreened, leading to late-stage diagnoses, more complex treatment needs, and poor health outcomes. In Hawaii, over 58% have late-stage diagnoses, and those costs for treatment is over $100,000. Hawaii is expected to see an increase in residents losing health coverage when Medicaid work requirements begin in 2027. For these individuals, access to screening will become even more limited. Colorectal cancer is one of the most preventable and treatable cancers when detected early, yet it remains the second leading cause of cancer deaths in Hawaii among men and women combined. A recent ACS study published in the Journal of American Medical Association found that colorectal cancer is the only major cancer with rising mortality among people under 50, increasing by about 1.1% since 2005. In 2023, colorectal cancer became the #1 cause of cancer death in this age group, an alarming shift that makes it the fastest growing cancer threat to working aged adults. Investing in screening today will save lives and reduce long-term costs to the state and ensure that those at greatest risk, the uninsured and underinsured, are not left behind. Mahalo for the opportunity to testify in support and for your commitment to the public health of our community. Thank you.
Okay, thank you, Cynthia. Let's see, we have also from the American Cancer Society, Daryl Kurosawa in support. Hawaii Medical Association. Good morning.
Aloha, good morning, chairs Martin and Takayama. I'm Dr. Elizabeth Ann Ignacio. I am the Maui physician and representing Hawaii Medical Association. I appreciate the comments of the American Cancer Society as well as the UH. We stand in support of this measure and are available for questions.
Thank you so much, Doctor. Let's see, we have white colorectal cancer, Harry Berg in support. And we have testimonies in written support from, let's see, 14, 15 individuals. Have I missed anyone else who wishes to testify on House Bill 1969? Anyone on Zoom? Okay. Okay. Dr. Lewin.
Yeah, chairs and vice chairs, I just shifted, wrote testimony this week for about 90 bills. We didn't write one for this because we were trusted that we have many other resources here to support this. And notwithstanding the
Just for
difficulty.
the record, although we all know who you are.
Oh, Jacqueline, shifted. And notwithstanding the difficulty of the screening process for colonoscopy, this really is an important area for us, and we have a long way to go. So we do appreciate your support.
Thank you. Let's see, with that, anyone else wishing to testify? If not, members, any questions? I do have a question for DHS, Marilyn.
Right.
And I just wanted to have you tell us how much the cost would be for this implementing this measure.
Sure, it could be between $1.4 to $2 million annually. This is an estimate, and then on top of that, some administrative costs.
1.6 to 2 million.
Yes,
Okay, thank you very much.
This is a follow-up. You said you maybe 1 FTE for
yes,
to manage it.
yes.
I'm sorry.
I'm sorry. Hi, good morning. I just have a question. How much time would it need for the department to create these new positions that would be needed and to fill those positions?
Sure, that could take, thank you, I appreciate that question. It could take some amount of time, hard to estimate. I would, if we're able to move very quickly, I would say then maybe anywhere between 6 months to a year to establish a position description, receive a position or re-describe an existing position, and then we'd have to create the rules. So I think just to make sure we're managing expectations, that there would be an amount of time, I would guess between 6 months to a year to get this fully established.
Okay, and I'm sorry, a follow-up question to that. Would this bill need to be passed in order to create those positions, or could those positions be created prior to this bill being made into law?
These positions could, a position to manage this could be created. However, if we wanted the position to specifically target colorectal screening and colorectal screening only, then we would have to have a reason that we'd have to tie to a reason that we're establishing such a position.
Thank you.
Thank you.
Thank you very much.
Alrighty.
No other questions? Let's move on to the next bill, which is House Bill 1965, relating to requiring all health carriers to allocate no less than 6% of the carrier's total medical expenditures to primary care providers. First up, we have Insurance Commissioner.
Good morning again, chairs, vice chairs, members of the committee, Justin Chu for the Insurance Division. The Insurance Division has submitted a number of comments on this, so I'll try to summarize and keep them brief. So with regards to the premium freeze, the department's concerned that it conflicts with our current standard that insurance rates not be excessive, inadequate, or unfairly discriminatory, which could create unactuarially sound premiums. Second, with regards to the definition of the MLR, the medical loss ratio. Medical loss ratio is a term defined by federal law, and CMS calculates what that MLR is. Insurance also calculates, but CMS is the entity that determines what that MLR, how it's defined. So, a state law that tells CMS how to calculate the MLR, I don't think would work. Next, regarding the external review process for downcoding claims, we note that we don't have an external review process currently in statute, and so we would prefer some. If the committee of the legislature would like to move forward with this, we'd prefer guidance on what that external review process would be, or if we were, whether currently we have an external review process for medical necessity, and we administer that process. That review goes to an IRO, an independent review organization. And so it's unclear whether this would have us administering a similar or doing the external review ourselves. And then there are a few sections, the new section -E, -J, -Q, and -K that create new authorities for the commissioner, and we just note that these powers already exist within the insurance code. Section -I requires us to, the insurance commission to have a public reporting format, and we would just prefer more clarity as mentioned in our comments. Section -R requires carriers to cover medically necessary inter-island transportation.
No, please proceed.
Okay, sure. We think this would be a new mandate that would require an auditor study, determine the cost analysis of the coverage, and then also could trigger ACA deferral. And then finally, there are a few terms in the measure that we think could use definitions or clarify. Thank you.
Thank you, Justin. You did a great job of summarizing very lengthy testimony. Appreciate it. Let's see, next up, State Health Planning and Development Agency, Dr. Lewin.
Good morning, Chair Takayama, Chair Martin, Vice Chair Gail Kapoli-Loy and Olds, and honorable members. SHPTA really thinks this bill was thoughtfully crafted by the physician community, and we think that every provision here has merit. But I'd like to distill it down to what's the most important piece of it, which is expanding our investment in primary care. Of the 38 OECD nations, richest nations in the world, we're the only one that hasn't recognized the value of this. There are insurance entities on the mainland and companies that are investing more than 10%. The goal would be 12 to 15% of total healthcare spend. The word medical loss is kind of an unfortunate term. It means the percent that's not administrative, just the healthcare spend. And we know that this will result in lower healthcare costs, better outcomes, and it's just absurd that we're the one nation out of the 38 that hasn't recognized this. I might just mention the other 37 nations spend about 7% of their GDP on healthcare. We spend 17%. And they all have better healthcare outcomes than we do. So we need to learn this. It's going to be a little bit of a painful transition process because it probably will have a temporary premium increase as we get there. But in the long run, this will save a huge amount of money. So I like to say that's the most important facet of this bill. We should find a way as a state to move in this direction and to just do this together. I will also mention that the Department of Human Services, MedQuest Division, and SHPTA are the partners in the AHEAD grant. And this grant requires over 8 years that we get to this goal. So this is a goal the federal government has. This is a goal that we should have. Other states are moving in this direction. Let's take action. Thank you very much.
Thank you, Doctor. Let's see. Hawaii Healthcare Task Force, I believe on Zoom, Dr. Scott Grosskreutz.
Good morning, Chairman. My name is Scott Grosskreutz. I'm the president of the Hawaii Healthcare Task Force and a physician on the Big Island. First, I want to thank all the members of these committees that have introduced this bill. We're very grateful for that. We're all well aware we've got a chronic and worsening shortage of doctors throughout the state of Hawaii. The extent of the doctor shortage on Maui and the Big Island is now over 40%. And, I can assure you, based on both mathematics and biology, that shortage on the neighbor islands could get much worse. We could reach the 60 to 70% range of physician shortage on the neighbor islands. First, we have multiple primary care clinics on both Maui and Hawaii counties that are at severe financial distress. Just in the last month, that may have to close. We've got a quarter of the state's doctors in Hawaii are already over age 65. And on the Big Island, about a third of us, myself included, are already past retirement age. As these senior providers retire or die, that just puts so much more additional stress on our burnt out remaining primary care providers, which is going to force a lot of them out of the current market into primary direct payment models. And that means that if you're a Medicare or Medicaid patient, particularly on the neighbor islands, you're going to be in a world of hurt. At a bare minimum, primary care reimbursements have to be increased to 6% by January of 2027 just to keep these clinics going. There's been a lot of other states, as Dr. Lewin mentioned, like Connecticut, Delaware, Oregon, Rhode Island, and Virginia have already passed similar bills that put the primary care spend to about 11 to 12%. California and New York and other large states are also considering this. So it can't be said that, oh, maybe some challenges that this can't be done, because this has been done repeatedly already in the United States. I think in hindsight, everybody in Hawaii can appreciate that however expensive it would have been to have fire mitigation measures in place on Maui, that could have prevented the catastrophic line of fires that so damaged that community, would have been worth it. There'll be billions of dollars spent on settlements and also on rebuilding from that. And on a similar vein, we basically have our primary care network, the private practices throughout the rural areas and the neighbor islands. They're basically on fire. And if they go down, and many of them are,
Please,
we'll be in the position where costs will skyrocket because we have so many more patients going to the emergency rooms, unnecessary hospitalization, advanced cancer care. So I'm just really encouraging the committee to hear this bill and pass it.
Thank you, Doc. I'm sorry, I skipped over the State Department of Human Services.
Aloha chairs, vice chairs, Meredith Nichols for the Department of Human Services. The Department of Human Services supports the intent of this measure. We did offer some comments suggesting that a broader definition of primary care investments extending beyond payments made to primary care providers to additionally consider investments in specifically beneficial primary care services and primary care supports and reductions in low-value primary care services. Continued investment in high-quality primary care has been shown to reduce unnecessary hospital visits, leading to overall savings in healthcare spending. DHS strongly supports increased investment in primary care and encourages such investment through its Quest integration contracts. And here's the good news. In calendar year 2024, the 5 managed care organizations in the Quest integration program invested at least 9% of their total medical expenditures on primary care, with 7% of the payments supporting primary care visits, 1% supporting quality bonus payments, and 1% supporting beneficial primary care services such as screenings, immunizations, and other preventative healthcare interventions. The Quest integration program spent an additional 3% on primary care supports, defined as supportive services needed to prevent readmissions and poor health outcomes, such as care management, mental health and substance use treatment, and supportive housing, and identified 1% of payments in low-value primary care services. So in 2025, with legislative support, the MedQuest division increased its investments in primary care by increasing the Medicaid fee schedule to 100% of Medicare. And DHS also remains strongly supportive of continuing to increase beneficial primary care spending by leveraging, as you heard from Dr. Lewin, the AHEAD grant, working in close partnership. Mahalo.
Thank you very much. Let's see, we have written support from Hawaii County Council member Jen Kagiwara. Next, let's see. Hawaii Healthcare Task Force, David Eastley. In support. Oh, I'm sorry.
Chair and members of the community, thank you for hearing this. My name is David Issei. I'm the Executive Director of the Hawaii Healthcare Task Force. I'm going to keep this short because there's a saying that says necessity is the mother of all invention. We are past that place right now. We are in a place of survival, most especially on the Big Island of Maui and then some. So to keep this really concise, I would say at the center of this bill is the medical loss ratio. So let's look at that, MLR. While the MLR is meant to show how much premium dollars are spent on healthcare, In practice, it often reflects how spending is classified, not whether patients can actually access primary care. Plans can appear compliant on paper while primary care declines and clinics remain unfunded and unable to stay open. So there are so many ways we can look at this. There's support for it, there are comments on it, hey, maybe we can make amendments on that, but we are not in denial of what the problem is. So if at all, let's look at the MLR part of it and actually do what is right for Hawaii. Thank you.
Thank you very much. AARP, Hawaii?
Good morning, Chair Takayama, Chair Martin, members of the committee. I'm Audrey Suga Nakagawa, Advocacy Director for AARP Hawaii, and we stand in strong support of this bill. You know, you're hearing all the technical complexity and the administrative complexity of this bill, and definitely they're all very well appreciated and understood. What I want to share with you is the consumer's perspective of the importance of having primary care, the number of our physicians retained in our Hawaii, and recruiting more and more as our aging population grows. How many of you have tried to get a doctor's appointment when you're sick? It's becoming really hard to get a same-day appointment with your primary doctor because they're overloaded with all the other patients that they have now had to absorb because of the growing increase, the shortages of the primary care physician. We know the importance of the primary doctor, especially as one person ages, because of the complexity of the healthcare problems that tend to arise when one person ages. Just to give you an example, when my father was working and throughout his adult life, he was very healthy, he had only one doctor. He turned 67 and all of a sudden he inherited 5 doctors because all these health problems started to surface. And if it wasn't for his primary care doctor, who was the captain of the healthcare team, he was able to have really ultimate care with good coordination, good communication, streamlining all his medication, and he lived on for another 20 years. This is an example of how important the primary care doctor plays, especially in our healthcare system. And definitely the problem of them leaving Health Hawaii, retiring early, and not being able to recruit new, younger doctors to take place in the healthcare system is going to become even more of a pressing problem as our population ages. And I just want to also point out that this is not an issue just for the older adults, but it is also for our young people. As our children and grandchildren ages out from their pediatrician, they need a primary care doctor too. So thank you very much. We really appreciate this effort to strengthen and increase our workforce of among physicians. Thank you.
Thank you. Hawaii Medical Association?
Chairs and committee. Dr. Elizabeth Ignacio, Maui Physician, Hawaii Medical Association. We support this measure. We think this is a great measure. We did add some amendments that we offered in our testimony just to clarify the definition of the community access primary care site that reassures that it's a qualified licensed healthcare provider with appropriate referral capabilities when necessary and reasonable patient support navigation services for preventative care and future comprehensive continuity of care. This is really important so that we're supporting our investments that are supporting long-term care of our patients. But we thank you for hearing this measure, and we support it. Available for questions.
Thank you. On Zoom, I believe we have Mohala Health, Dr. Esther Smith.
Hello, thank you, Chair Takayama and Vice Chair Leloy. I don't need to extol the virtues of primary care, for all are in agreement that the intent of this bill is solid. So what we are left to discuss is it possible or practical? Well, that MLR we keep talking about, which allows insurance companies to keep 15 to 20% for administration and the rest have to go to medical care, is proof of the concept that we can regulate the percentages of how these dollars are spent. And let's acknowledge that most of it is our tax dollars. The second thing is it possible? And it's possible without increasing premiums. And the example I just want to give is that during the pandemic's shutdown, when there were almost no doctor's visits and there were no elective procedures done, the insurance companies saw the greatest revenues they ever saw. And they were able to maintain that exact ratio, 15 or 20%, despite the decreases in services. That's the kind of control they have. And immediately after, or during the shutdown almost, in Hawaii, one of our largest insurers moved 230 jobs from Hawaii, despite having had record income. There are ways to maintain premiums at their current levels and increase the primary care spend. They are numerous. And the argument should not be made that it's impossible. In the last few seconds, I wanted to talk about this bracelet, which was given to me by a patient's daughter because her mother broke her neck and was stuck in the hospital. This is only a few more seconds, and had come out of the hospital and was homebound, and they could not get her in and out of that building again. But insurance companies require an in-person visit in order to get home health services. She did not have a primary care provider because her primary care provider had died. And so I went there and I saw her and she became my patient. They need more of us. And the only way there's going to be more of us, or even keep the ones we have, is with more support. Thank you.
Thank you, Dr. Smith. HMSA?
Chairs Takayama, Martin, Keo Kapulino, and Olds, Alden on behalf of HSA. We support the intent of this bill, continuing to invest in primary care, allowing for access. I mean, they are the lifeblood and first line for all of our members. And for HMSA, we exist because of our members, but it doesn't happen in a vacuum. There's the hospitals, the providers, all of this healthcare system is what allows our members to get the adequate and highest level of care that we as an organization strive to provide for them as well as residents across the state. We do have some concerns in some of the mechanisms as to how to get to the 6% and the eventual tiered 12% in 2029 without increasing premiums. We don't necessarily know where that increase of spend potentially would come from, which is typically borne by our employees as well as other payers into the system, as well as removing or limitations of risk and quality control metrics. Previous testifiers have brought up other states that have mandated percentages of medical spend tied to primary care. 5 that we've found: Virginia, Connecticut, California, Oklahoma, and Rhode Island all continue to utilize quality metrics in their, calculations of coming up with this, as well as coming through a task force or working group with various stakeholders, including physicians, payers, as well as consumer protection advocates. So at this time, we appreciate you accepting our testimony. Happy to answer any questions. Thank you.
Thank you. On Zoom, Waianae Coast Comprehensive Health Center, Ian Ross.
Aloha, chairs, vice chairs, Ian Ross with Waianae Comp. We put comments forward and we want to say that we do support the intent. In addition to our written testimony, we do want to concur with AHARA Hawaii, of which we are a member. Their testimony outlines our concerns in more detail, offers areas for potential amendments for this measure, or areas for consideration for your committees this session and beyond. Thank you very much for this opportunity to testify.
Thank you. Let's see, that's all the testimony I have in person or on Zoom. And we have, in addition, about 24 other testifiers either offering support or comments. Have I missed anyone else wishing to testify on House Bill 1965? Seeing none, members' questions? Sure. Yeah.
I have a question for the task force, please, if you wouldn't mind coming up. So just to understand better, when we talk about what they've done in other states or what your vision is, when you talk about increasing the percentage, is it just as simple as increasing the payment for primary care services? Is it doing more of what Medicaid was talking about, of like ancillary services like case management, or what would that extra money go to? What would it look like?
So, ma'am, the way it is right now, is those funds are not allocated for what they're supposed to be doing. So it's a shortage of the funds we're not receiving. So everything that covers primary care, it covers that. So it also goes into alleviating administrative burdens, and then which is putting them in a bottleneck where they have to shuttle if they want to do administrative services or they want to do medical services. So it dovetails into hiring, it dovetails into prioritization, spending time in prioritization, not able to hire staff. So those other states that have done that have been able to increase those percentages where you actually enable people to stay in the job. So that's basically what it boils down to.
So I'm not sure if I understood you. So more of the payment that is coming already for primary care would get allocated differently?
Correct.
More towards direct service,
Direct
less
service.
towards administration.
Correct.
Okay, but you're not thinking that we need rate increases, like Medicaid did rate increases to match Medicaid did rate increases to match Medicare. You're not suggesting that our private health insurance organizations need to increase their rates for primary care services?
We're not suggesting that.
Okay. All right, thank you. Thank you, Chair.
Okay, thank you. Representative Obama.
Thank you, Chair. I have a question for HMSA, please. I'm curious, we've heard a lot of the impending merger with One Hawaii Health. Will your impending merger lead to an increase in access to primary care for your members?
You know, Representative Amata, thank you for the question. At this time, I don't think I would be equipped to answer that specifically. I'd be happy to get you more information if you'd like after.
I would appreciate that. Thank you. Thank you, Chair.
Thank you. Any other questions, members? Representative Kaupalima.
Not for HMSA, but for DCCA or thank you.
Insurance Commission.
Insurance Commission, thanks. I was really curious on your section of your testimony, section 431 mandates no healthcare carrier shall raise premiums to meet increased primary care expenditures, which that directive is at odds with the internal, like our insurance code. Can you expand a little bit on that?
Sure. The insurance code says that rates shall be set, so they're not excessive, too much, inadequate, too little, or unfairly discriminatory, right? So, I mean, we've heard a lot of testimony about whether or not allocating more to primary care would increase or decrease costs. From my understanding, and I believe what Dr. Lewin alluded to as well, is that, it's a spend upfront, save later kind of system, right? So we invest more in primary care now, and healthcare costs are saved overall based on, lack of services down the road, right? But insurance rates are set year to year. So we might see an increase now, it might cost more now. So if this bill caps the ability to do that, then we might see inadequate rates. That's our concern. And it could be that, we see some savings now as well. It's just that there's a handcuff, right? In the worst case scenario, maybe they do need to go up, and then but the bill would hamper the ability for the insurance division to be able to determine that.
Okay, and then you mentioned the guidance regarding to the regulations. It was unclear about whether that internal review becomes the external review. Can you also expand
Sorry,
on?
this is for 431D.
Yes.
Okay, sure. Yeah. Let me see what the bill states. Okay, so this is regarding downcoding, and it says that each subsection D on page 8, it says each downcoded claim shall be subject to expedited external review, and final determination shall be issued within 15 calendar days. So I brought up an analogy earlier to medical necessity. So you know, there's an insurer review about whether or not a procedure is medically necessary. And if the insurer determines that it's not, then they can ask someone else, independent third party, to do so. And I assume that this asks for the same thing, that if the insurer has a dispute about downcoding and the insurer says, no, this is correct, because the first right of review goes to the insurer, then the physician or healthcare provider can ask for an independent party to do that. And so our concern is that we have a statute, 432E Part 4. It sets up a process for this external review. And here, it just says to do an external review, which we don't have a process.
Okay, thank you. Thank you for that clarification. Thank you, Chair.
Okay, thank you, members. If no other questions, let's move on. House Bill 1804 establishes a legislative long-term care financing advisory commission to examine the feasibility of options for long-term care services and supports. First up, we have Legislative Reference Bureau. Offering comments. Department of Human Services.
Chairs, vice chairs, members of the committee, Meredith Nichols on behalf of Department of Human Services. And we're standing in support of the establishment of this long-term care financing advisory commission so that we can really dig in and examine the feasibility of different financing options for long-term care services and supports. And then, of course, we also support the bill's requirement that the director of DHS and the administrator of the DHS MedQuest division or their designees serve as ex officio members of this commission.
Thank you.
Mahalo.
I should note for the record, even though LRB, Legislative Reference Bureau, is not here, that in their written testimony, they expressed concerns about the measure, even though they don't take a position. And they said that LRB notes that it does not have any specific expertise in long-term care services, financing, and insurance, actuarial assessment, or fiscal analysis. They do other things. So let's move on to Department of Health. In support. I'm sorry, Department of Health, Office on Aging.
Caroline Cadirao, Director, Executive Office on Aging, will stand in strong support of this measure. Thank you.
Okay. Dr. Jack Lewin.
Good morning again, chairs, vice chairs, and members. This bill actually originated in the Kupuna Advisory Council for the State Health Planning and Development Agency. The council looked toward the problems we're facing in terms of the expanding costs of long-term care, the unavailability of services to people of lower income in many instances. And this is a planning process and one that we really should undertake as a state. Back in 1990, our Executive Office on Aging did put forward a large plan to finance this kind of work, because if you're gonna finance long-term care, we have to start contributing to the financing when we're young, not when we're 5 years from retirement. So it's a matter of small amount of investment all through life can produce the resources needed. So we have for people that are eligible for MedQuest, we have much more availability of services, but so most of our kupuna are not. And these are the people that are suffering when they really need care in the long-term area and their families. So this is a really great planning process. We should undertake it. Thank you very much.
Thank you. AARP.
morning, Audrey Suganakagawa from AARP, and AARP stands in strong support of this measure. God, I feel like I'm really aging because I do remember when in 1990s the Family Hope program was going on, and I do remember in 2011 there was a commission that actually tried to tackle this issue. So this is long overdue. Really appreciate the effort, and I'm getting close to where I might need long-term care soon. So please, I really hope we can find some solutions. Thank you very much.
Okay, let's see, Healthcare Association of Hawaii on Zoom. Paige.
Good morning, chairs.
Okay.
Hi, good morning. We'll stand in support of this measure with the Healthcare Association of Hawaii. Our only request is to potentially add other types of providers of long-term care, including skilled nursing facilities, assisted living facilities, and home health agencies as part of the commission to provide that perspective to any report. Thank you.
Okay, thank you. Let's see, we have testimony from about 8 other organizations and individuals, and all of them in support. Have I missed anyone who wishes? Please step forward.
Hello, Chair and members. My name is Melissa Pavlicek. I'm here on behalf of Leading Age Pacific West, and we submitted some support testimony, but it was quite late, and I just wanted to note it for the record. Thank you.
Okay, thank you very much. Let's see, again, anyone I missed? If not, members, questions? No questions, okay. Let's move on. House Bill 1976 requires the provision of at least 1 hour of dementia-specific training for first responders. And first up, we have Executive Office on Aging.
Good morning, Chair Takayama, Chair Martin, members of the Joint Committee. I'm Caroline Kadira, Director of the Executive Office on Aging, and we support the intent of House Bill 1976 related to dementia. As you said, it requires 1 hour of dementia training for our first responders, and it requires Executive Office on Aging to review and recommend the training for first responders. We have 3 recommendations that we'd like to share. The first is making an amendment to adjusting the training start date. Right now in the bill, I believe it says January 1st, 2027. We're asking due to our strained workforce capacity if we could move that by 6 months to July 1st of 2027. And that also allows the Enforcement Standard Board to have time to review the trainings that are being recommended. Also, to align with the change in the start date, we need to, the cycle completion date change to June 30th of 2028. And then under our HRS 349 for the Executive Office on Aging, we ask that we strike out lines 15 through 22 about low cost, no cost dementia-specific training curriculum for nonprofits. And we'd like to replace it with the Executive Office on Aging shall seek low to no cost dementia-specific training curricula. The Executive Office on Aging shall identify whether the training has an associated fee or no cost in the development of the curriculum list that we're going to put together. Thank you so much for this opportunity to testify. I'm available for questions.
Thank you.
Thank you.
Hawaii Emergency Management Association, HIEMA. Offering comments. AARP.
AARP stands for our testimony and support.
Alzheimer's Association Hawaii.
Hello, Chair Takayama, members of the committee. Thank you for scheduling this bill. This is so important. As you all are very familiar, I think we met with each and every one of you at some point, and you all understand this issue. We have about 31,200 people living with Alzheimer's in the state. We're expecting this number to double in the next 25 years. It is not uncommon for someone living with dementia to wander at some point in their life. About 60% of people is what we estimate. And in terms of wandering, you have people who go out and about and they don't have the same reality that we all do. They're experiencing something that's a little different, especially in the middle to later stages of the disease, and we want to make sure that our law enforcement agencies are well suited to handle these situations so it doesn't escalate to anything more than it needs to be. On the other hand, you have a lot of readmittance of people living with Alzheimer's into the ER. We have about 1,248 people who are going to the hospital or ER for every 1,000 people living with Alzheimer's. So we're always seeing people go back to the ER, and more often than not, when it's a very dire case, EMS is going to respond and they need to be able to manage the situation properly. And then finally, you all know that our state has been seeing an increased number of wildfires and other natural disasters. So when fire responds, we need to make sure that they're able to communicate effectively with the people living with Alzheimer's, because again, they don't live necessarily in the same reality that we all do. So if you have someone who is experiencing smoke in the house, a lot of heat, you can imagine it's already kind of a chaotic situation. And then you have this man or woman who's kicking down the door, you don't understand what's happening, but you're in this sense of and state of panic. It's important that we're able to kind of manage this situation to keep all of our kupuna and loved ones impacted and living with Alzheimer's disease safe in these situations. So we thank you again for hearing this bill, and we ask for your support in passing it through. Thank you.
Thank you very much. On Zoom, I believe we have Barbara Black.
Good morning, chairs and members. My name is Barbara Black, and I live in Nanoli in the Big Island. And I am a caretaker for my husband, Peter, who has Alzheimer's. I strongly support this bill to ensure the safety of those living with Alzheimer's. It breaks my heart to think of Peter wandering somewhere confused and possibly frightened, being treated harshly and without compassion. I remember a neighbor out walking and clearly unaware of who we were, but who took our hands with a smile as we walked her to her home. And while most people are kind and caring when they see an uncertain and possibly lost person, and I'm always grateful to be living on this wonderful island, that may not always be the case. And 1 hour of training each year for first responders, which is already provided by the Alzheimer's Association, covers communication techniques, de-escalation strategies, recognizing the signs of dementia, and how to safely help someone. I respectfully urge you to support this bill so that Hawaii's first responders have the tools they need to interact safely and effectively with people living with dementia. And so people like me can feel more confident that their loved ones will be treated with understanding and care during an emergency. Thank you for the opportunity to testify.
Thank you. Now, also on Zoom, I believe we have Peter Black.
Yes, you do. Oh, wait, you said it. Hold on.
Oh, yeah. Oh, shit. I'll just give it this. All right, I'm ready. Hello,
Please go ahead.
I'm sorry about that. So, yeah, I have Alzheimer's. It's no fun. I'll just read you a little thing I wrote. I have no clear idea of what my future will be. But if I live long enough for my dementia to render me incompetent, be on my own, I really hope any encounter I might have with a first responder, be it a policeman or a fireman or woman, is an encounter with someone who is ready to deal with me appropriately. Thank you very much for the opportunity to testify.
Thank you very much, Mr. Black. Best of luck to you.
Thank you.
Let's see. That's all the testifiers I believe we have on Zoom or in person. We have about 8 to 10 others, organizations and persons and expressing support for this measure. Anyone I missed who wishes to testify on this? If not, members, any questions? Seeing none. Before we move on, I just need to add a personal anecdote that Colby from Alzheimer's Association knows about. My dad suffered from Alzheimer's, and years ago, he actually wandered off in the middle of the night, and a Kaneohe policeman found him sitting on a playground swing, eating a box of Chinese takeout food, which to this day we have no idea how he acquired because he didn't have a wallet with him. And a policeman told him that you contacted your family, someone will come by to pick you up. And we did. But I just wanted to point out how important it is to interact with those who suffer from Alzheimer's or dementia on a very compassionate basis, which in this case we were fortunate, so fortunate to have experienced. But I think this is an important measure. Next bill, HB 1530, relates to residential community treatment and requiring contracts to include certain provisions regarding residential treatment programs. And first up, we have Hawaii State Department of Health.
Good morning, chairs, vice chairs, committee members. My name is Kaylee Aquaro. I'm the administrator for the Child and Adolescent Mental Health Division, and I'm here representing the Department of Health today. We did provide testimony offering comments on this measure. While we appreciate the intent of the measure, we would want to just flag a couple of concerns. One being that the additional requirements are potentially stigmatizing for the youth who live in these homes and the adults who live with and care for these youth. And also that the proposed increased requirements could add additional challenges to providing community-based mental health residential care for youth in need of this level of support. We would respectfully suggest that the current requirements for programs of this type are adequate to address the needs of youth communities in the state, and that we already have the authority to adjust any contractual requirements if that was deemed necessary. So we don't believe that legislation is required to do that. Available for any questions. Thank you for the opportunity to testify.
Thank you very much. Department of the Attorney General.
Good morning, Chair Takayama and members of the committee. I'm Michelle Nakata, Deputy Attorney General. The Department of the Attorney General provides the following legal concerns and comments. The Federal Fair Housing Amendments Act and the Americans with Disabilities Act prohibit governmental entities from discriminating against persons with disabilities in housing. This bill would require any person applying to contract with the department or to renew or extend a contract for a youth mental health residential treatment program to obtain and maintain general liability insurance policy with certain minimum coverage amounts, submit for review and approval a community safety action plan to the department, and to provide the community plan to a community association and or a neighborhood board. It also requires the programs to provide written notice of the program's establishment and location to the community association or the neighborhood board. These requirements are not required for any other family homes. They only apply to small group homes for youth with mental health disabilities. Courts have found that written neighbor notice requirements and safety requirements that only apply to group homes for persons with disabilities may violate the Federal Fair Housing Act. Since this bill also requires the Department of Health to provide administrative rules to implement
this section. These requirements may also be subject to challenge under the Fair Housing Act. Our points are covered in more detail in my testimony. Thank you for the opportunity to provide comments.
Thank you very much. Catholic Charities of Hawaii. Comments or actually testimony in opposition. Thomas Lau. On Zoom.
Hi, I'm sorry. Can you hear me?
Yes, we can hear you. Please proceed.
Hi, I am a Newtown resident. The treatment facility should not be in a residential neighborhood. The IAEA Neighborhood Board overwhelmingly voted against the special treatment facility in Newtown. Catholic Charity used a loophole to bypass public hearing to put the treatment facility in a residential zone. I don't know why the state put a treatment facility for adjudicated sexual deviant teens in a residential neighborhood, bringing teens that must meet all the dangerous criteria Department of Health require for admission. This criteria ensure that only dangerous teens can be housed in a facility in a residential neighborhood. For the Department of Health, there are many needs for this type of facility. But because of Catholic Charity used a loophole to bypass public hearing, the facility is only limited to house 5 kids. Catholic Charity's application budgeted $5.5 million for the treatment facility for 3 years at a very high cost of $342,000 per teen per year. If Department of Health increases the maximum treatment facility capacity, more teens can be treated at lower cost per teen, but they need to open it up for public hearing. In summary, a treatment facility at this high level should not be in any residential neighborhood. Department of Health did not consider community safety and security in their certificate of need evaluation criteria. More than a year after the contract was awarded to Catholic Charity, they still don't have a safety action plan for the community. A safety action plan is a contractual requirement on Department of Health's contract, but they continually overlooking it. There are many risks to us. Please, please help us protect our family. I support this bill. Thank you.
Thank you. Naomi Yap.
Good morning, Representative Takayama and chairs, members of the committee. My name is Naomi Yap, and I'm here in strong support of HB 1530 relating to youth mental health residential treatment programs, specifically the provisions on community notification. HB 1530 requires that any person applying to contract with the department or to extend or renew a contract to operate a youth mental health residential treatment program must provide the following to the applicable community association or neighborhood board for the area in which the program will operate. Number 1, written notice of the program's establishment and location, and 2, the program's community safety program plan. These notifications are required as a condition for the department to enter into, extend, or renew a contract, especially for sexually reactive youth. This bill is important for several reasons. Number 1, transparency builds trust between agency, provider, and neighborhood. When a youth mental health residential treatment program is licensed and operating without informing nearby residents, it undermines good faith community relations. 2, early communication prevents escalation and conflict. And 3, community input is critical to the review and approval process. In conclusion, community notification is essential because it protects residents' welfare, upholds transparency, promotes collaboration, and ensures meaningful public participation in decisions that affect neighborhoods. For these reasons, I respectfully urge you to pass HB 1530. Thank you.
Thank you very much. Jeannie Omaye.
Good morning, Chair, Vice Chair, members of the House Committee on Health. My name is Jean Omaye, and I am testifying in strong support of House Bill 1530. This bill does not address the Fair Housing Act or the need for such a facility. The facility is already there. It addresses safety issues related to a facility that houses sexually reactive youth in a residential community. Following a collaborative effort involving the Aya Neighborhood Board, the Office of Information Practices, and the State Ombudsman, our community received a community safety plan for the special treatment facility which houses sexually reactive youth in our community. While we acknowledge the release of the document, upon review, we find that the plan fails to satisfy the child and adolescent mental health performance standards. Specifically, it lacks the policies, procedures, and mechanisms required to effectively manage the risk posed by sexually reactive youth to the surrounding residents. These include a 24/7 emergency contact number, specific protocols for when a youth elopes or leaves, or when 911 should be notified. The contracted service provider argues that these facilities help youth assimilate into the community. However, true assimilation requires an effort to be a good neighbor that starts with a plan that details the measures taken to protect both the residents and youth in their care. Currently, this facility, which houses sexually reactive youth, is in my backyard. I ask you, what happens when a facility like this is placed in yours? Will there be a safety plan in place to protect you and the people you represent? Government agencies and large private corporations have the resources to protect their interests. We don't. We are simply ordinary people living in neighborhoods across Hawaii. We turn to you to stand by us in our effort to keep our homes safe, protected, and untroubled. As our representatives, we ask you to join us in supporting essential safeguards in House Bill 1530. Thank you.
Thank you very much. Claire Yim.
Hi, Chair Takayama, Vice Chair, and members of the committee. My name is Claire Yim. I strongly support HB 1530 with an amendment. I respectfully request that your committee amend this measure to only include community-based residential to sexually reactive youth programs operating in a residential community in the definition of a youth mental health residential treatment program. At the end of July 2025, a community-based residential to sexually reactive youth program began operations. This program is a 24/7 special treatment facility serving 5 males ages 12 to 17 who have a history of challenges relating to sexual offending, aggression, or deviance that prevent them from participating in family and or community life. This is the only, I repeat, this is the only facility in the entire state of Hawaii operating this program in a residential neighborhood and operates as Hawaii's second highest level of care for adolescents just below hospitalization.
The organization said that they did not complete any community outreach because they were not required to do by law. Already 3 police reports have been filed for 2 violent incidents. So while I respect the organization operating the special treatment facility community to protect the safety of the community, notification and are important, especially in a residential area where children, adolescents, and elderly are living. HB 1530 will require youth mental health residential treatment programs to address safety concerns, provide notice to the community. I strongly support HB 1530 with an amendment that the definition of a youth mental health residential treatment program to only include community-based residential to sexually reactive youth programs operating in a residential community. Thank you for considering my testimony in support with the.
Thank you very much. Randy, you.
Good morning, Chair Takayama and members of the committee. My name is Randy Yim. I strongly support HB 1530 with an amendment. I respectfully request that the committee amend definition of a youth mental health residential treatment program to only include community-based residential to sexually reactive youth programs operating in the residential community. This community-based residential to sexually active youth program is a 24/7 facility serving 5 males ages 12 to 17 who have a history of challenges related to sexual offending, aggression, or deviant behavior. The special treatment facility is the only facility in the state of Hawaii operating in this program in a residential neighborhood and operates as Hawaii's second highest level of care of adolescents just below hospitalization. The facility is unsecured. The youth can leave anytime. If a youth elopes, the program's community safety plan is to call 911. Since starting operation in July 2025, 3 police reports have been filed for two violent incidents. I've included that in my testimony. The Pearl Ridge Elementary School bus passes this facility twice daily on the weekdays. The safety of the students must be a priority. Again, I strongly support HB 1530 with an amendment that the definition of a youth mental health residential treatment program to only include community-based residential to sexually reactive youth programs operating in a residential community. Thank you for considering my testimony in support with an amendment.
Thank you very much. Let's see, I have written testimony from about 20 other individuals, all of them in support. Anyone else I missed? Anyone I missed who wishes to testify on House Bill 1530, please step forward in person or in Zoom. Seeing none, Dr. Lewin.
Aloha, Chair.
You're so often
Jack Lewin. I feel the obligation to testify on this. I didn't actually see what the issue was, but I'd like to acknowledge that a certificate of need was issued for this facility, and it was extremely controversial. In the certificate of need law, we are not part of our statutory authority does not include selecting a location for a facility. So we had no jurisdiction in the sense of that. There was a public notice, but I do think the community has a real issue of concern. This particular facility was actually in another affluent community in Nu'uanu, where they lost the lease for their property. They'd existed there for quite a few years and without incident in that particular site. So the Catholic Charities and the Department of Health really thought this was safe. They've tried to build some issues around it. But I do think the community deserved to have early notice so that they could consider this together. And I think that is a legitimate kind of consideration for future. We didn't have that, we didn't really have the authority to do that then, but And while this is, no incident has occurred since then, and I think that DOH and Catholic Charities are doing their very best, I will just say that the kids in this facility are abused kids. They've been damaged. They need a facility somewhere, but unfortunately, this community didn't get a chance to really consider that in advance. So I think there's some merit to their concern. Thank you.
Thank you very much. Members, any questions?
Dr. Lewin, I could follow up. You mentioned the issuance of the permit, right? Is it obtained without a selected site?
The site isn't a determination that the certificate of need considers. We have 6 different considerations, but that's not one of them. But there is, there's some legitimacy to community wanting to have notice before something enters, their space. And that's true, I think, of substance abuse treatment facilities as well. These are things we should be thinking about in terms of where they're placed. Thank you.
Dr. Lewin, if I could follow up on that. Is that something internally where you guys would be able to tie the certificate to a place?
No, this is really, it gets down to actually it's a zoning ordinance issue.
Got it.
That is really where this should be a zoning ordinance.
Got it. Thank you.
Any other questions? If not, I have a question for Department of Health, please. You heard residents as well as Dr. Lewin make reference to the fact that there really didn't seem to have been any kind of community notification in advance. And I'm sorry that Catholic Charities is not here to speak for themselves, but can you talk about why perhaps there was no notification, no effort to alert the community as to the nature of this facility?
I can't speak on behalf of Catholic Charities. I do know that from the neighborhood board meetings that we've attended together, they have expressed remorse at not reaching out to the neighbors earlier on in the process. But I would just offer that no rules have been broken in the process of them being licensed as a special treatment facility or in the certificate of need process. They didn't violate any loopholes or anything like that. They have followed all the rules required as part of that process. And I've been started attending the neighborhood board meetings as a way to try to address questions and concerns that have come up about both the process and the program.
Can you tell us how many teenagers are being treated there?
It's licensed for 5, so at any given time, the census is dynamic, is admitted or discharged, but they're licensed for 5.
Up to 5?
Yes.
I had heard that there were actually 2 residents. Would that be about right now?
At different points, yes, I don't know what the number is today, but at different points there have been.
How long are they typically residing there?
A length of stay for a program of this type is typically 6 to 9 months. That's the course of treatment.
And are there any other treatment facilities like this contracted through the Department of Health right now?
We have other community-based residential facilities that are licensed as special treatment facilities. Some that are not in residential neighborhoods, and another one that is in a residential neighborhood.
And in the event you are to issue a new contract for a new residential treatment facility, is it possible, can you give us the assurance that you would make an extra effort to make sure that whatever community, and it could be any of ours, is notified in advance as to the nature of the facility?
I think absolutely in terms of that early communication being so important. I think what is challenging is that when we are putting out the competitive procurement process, we don't always know who's gonna get the award and where they are planning to locate the program. They don't have to have located the program at the time of the contract award. And so, there could be a sequencing problem with being able to do that, but we absolutely agree that early communication is best.
Thank you.
Chair.
Oh, go ahead.
So it seems to me that early communication is wanted by the community to oppose having that there. And I don't think that just because they knew about it before would make them feel any differently about the facility, right? The only real goal of that early information is to try to block the project. Is there, I know that when it comes to facilities with a mental health focus in residential areas, there's often conflicts with the neighbors. And for many of us that let our kids run free in the neighborhood when they were little, you could understand that a facility like that would change the way you parent and the way your kids grow up. And so it really does have an impact. I wonder, is there a reason that a facility like that needs to be in a neighborhood? Like, are there treatment benefits, like kind of a normal situation? Is that important for the kids in the program? Or could they be in a different kind of area, like a more commercial area or something like that?
It's a really good question, and there are absolutely substantiated benefits to youth with trauma backgrounds living in as normalized a setting as possible. So in a home, in a community, that really has a lot of benefit for young people who are trying to overcome trauma histories, and who are trying to learn how to function in normal homes and in supportive communities. And so as opposed to being in a more institutional setting, these types of programs have been shown to be really impactful and effective in treating the types of behaviors that these youth have. So yes, and since we're talking about evidence and data, I would also argue that there's no data to suggest that these young people pose a safety risk to their community. And so the additional requirements feel predicated on the assumption that they pose a safety risk to the community, but there is not data to suggest that they do.
Thank you, Chair.
Thank you.
Sorry.
No other,
Chair,
sorry, Representative Hartsfield.
I have a question, and I'm not sure if this is for Department of Health or the Attorney General's office. So my question is, trying to balance the safety needs of the community as well as the treatment needs of a child. If what is being proposed was in the administrative rules, would that address the concern that we're discussing today so that a law wouldn't be required? Or would including this in the administrative rules still be insufficient to meet the safety concerns for the community as well as the treatment needs of a child?
This bill did require the Department of Health to adopt administrative rules, and if they adopted all the same requirements, our testimony is that it may be subject to challenge under the Fair Housing Act, because it would be the state adopting these administrative rules, and states cannot discriminate against persons with disabilities in housing.
Okay, thank you. So this doesn't sound like an easy solution. It sounds like it's something that zoning needs to be involved with as well. That's what I gathered from today's testimony. Does the AG's office think along the similar lines? All right, thank you so much.
That was a nod, yes.
Yeah,
For the record.
Okay, any other questions? If not, members, let's move on to the next bill. Thank you very much. I just want to thank the residents from IAL who traveled from, I'm sorry, you cannot, but I just wanted to express my appreciation for traveling from IAL to take part in our discussions today. We appreciate very much so your coming here and expressing your views. Thank you. Next bill is House Bill 1541. proposing to exempt certain positions at the Hawaii State Hospital from civil service. First up, Hawaii State Department of Health.
Good morning, Chair, members of the committee. I'm Courtney Matsu, Department of Health, Behavioral Health Administration. We support this measure, which exempts certain key critical leadership and operational positions from civil service in both the Division for Development of Disabilities and Hawaii State Hospital. I have our administrators here from those two sections to answer if there are any other questions.
Thank you very much. Let's see, we have written testimony from HGEA, Randy Pereira in opposition. Anyone else wishing to testify on House Bill 1540?
Hello, Chair, Vice Chair.
Please proceed.
Good morning, members. Nui Sebas for HGEA. We submitted written testimony in opposition. We just wanted to just explain our concerns that by exempting positions, these employees won't be covered under just cause protections and making these employees at will. We understand, we'll note that there are other ways to help with recruitment of these positions, such as adequately pricing these positions to be competitive with other public sector jurisdictions or the private sector. Thank you.
Anyone else wishing to testify on House Bill 1541? Seeing none, members' questions? Seeing none, let's...
Chair, sorry.
Oh, I'm sorry, Representative Hartson.
Thank you. A quick question for DOH. Thank you. You know, I understand the need to exempt positions. I know that it makes hiring a lot quicker and it makes the ability to be more competitive when trying to fill those positions. So my question is, these positions that the department wants to exempt, are they existing positions? And if they are, how long have they been in recruitment?
So I'll have
Good morning, Mark Lynn Scott, Hospital Administrator for HSH. In that question, these positions, so Act 230 and House Bill 1800 in the year 2024, approved appropriations for many of these positions for us. So it's been at least 2 years. We're in a reorganization that I've been told, so this is prior to my administration, I'm trying to use those dollars. So right now, to the point of labor, we're using contract workers to fill the gap. And these positions were specific for security and safety of our employees and staff. So we're trying to do the right thing here to expedite them getting filled. Many of those positions, like the leadership position, should be exempt from that because there is, we work for the mission of the organization. So I hope that helps. So 2 years ago, and so we're still in a reorg for our department and separated out the division. So we wouldn't be able to use those real dollars until 2027 if we do the formal process, which, by the way, we have done. So the default is we're going to make them civil servant if the process is taking an enormous amount of time.
All right, thank you.
Good.
Oh, I also want to follow up because we do have one position in developmental disabilities. If you have a question about that position.
Good morning, Chair, committee members. My name is Ryan Lee, Acting Administrator for Developmental Disabilities Division. This is a new position for us, so we have no history with it. We're requesting support.
Thank you.
Thank you. If there aren't any questions, let's move on to the next bill, which is House Bill 1542, which would allow terminally ill patients and qualifying patients over 65 years of age to use medical cannabis in certain healthcare facilities. First up, Department of Health.
Morning, chairs, vice chairs, and members. Andrew Goff, the Office of Medical Cannabis Control and Regulation. This bill would essentially require the majority of facilities, healthcare facilities in the state to allow patients that are terminally ill and patients over 65 with chronic conditions to use medical cannabis at the facility. There are some limited exceptions. The issue is, now first, I want to make sure that it's clear that we support the intent of this bill. Medical cannabis can be extremely effective for treating end-of-life conditions and easing end-of-life transitions, both for the patient and for the families. The ultimate issue is the federal law is not there yet. While the president has indicated a desire to move cannabis from Schedule 1 to Schedule 3, which would recognize the medical value of cannabis, we do not yet have a timeline for when that will happen. We don't have a process for how that will happen, and we don't know what that will eventually look like. So our recommendation at this time is to change it from a requirement to an authorization under state law, so that facilities can, under state law, allow the use of medical cannabis for these conditions, but are not required to violate federal law if they choose not to. And I do want to note that last year, with the help of the folks in this room, we were successful in expanding the medical cannabis program to allow for hospice providers and palliative care providers to certify patients for medical cannabis. And as part of the rulemaking process, we are going to be doing outreach and education for those providers to let them know what the rules are, what the law is, and to address any concerns they may have of medical cannabis in their facilities. So I do want to thank the committees for engaging in the discussion and for supporting our patients. And I'm here for any questions you may have.
Okay, thank you, Mr. Goff. Office of the Attorney General on Zoom.
I'm in person.
Okay, here you are.
Good morning, Chair, Vice Chair, and members of the committee. Alana Bryant, Deputy Attorney General. I'll briefly highlight the comments in our testimony. The comments are very similar to what Mr. Goff just stated. We note that at this time, cannabis is still a Schedule I controlled substance under federal law. And because of that, we recommend making accommodation of medical cannabis in healthcare facilities permissive rather than mandated. We noted that the president did sign an executive order in December 2025 directing the U.S. Attorney General to reschedule cannabis to Schedule 3, which may reduce the legal risk to healthcare facilities. However, we don't have a time frame for when rescheduling might actually occur or what rescheduling would actually look like. Thank you, and I'm available for any questions if you have them.
Thank you very much. Let's see, we have testimony in opposition from Hawaii Substance Abuse Coalition, Ina Malka, and Big Island Substance Abuse Council. On Zoom, I believe we have Hawaii Cannabis Industry Association, Tai Cheng.
Good morning, Chair, Vice Chair, members of the committee. If you can hear me, my name is Tai Cheng, Chairman of Hawaii Cannabis Industry Association, and I'm here today in support with comments of HB 1542. This bill is about compassion and timely access to care, especially for terminally ill patients and seniors with chronic conditions. And for these patients, medical cannabis is not experimental, nor is it recreational. It's a proven tool to help them manage their pain, appetite loss, and anxiety. At the federal level, the Attorney General has already mentioned that President Trump has directed the rescheduling of cannabis to Schedule 3 under the CSA. This is where Tylenol with codeine is also categorized. This reflects that growing consensus that there is medical value to cannabis and that the safety profile is comparable to many commonly prescribed medicines. Despite this recognition, medical cannabis patients in Hawaii, particularly the elderly and the terminally ill, still face delayed costs and burdens to get their medical cannabis. HB 1542 allows for the medical use of cannabis in some health facilities, but timely access still remains an issue for this population. When someone is facing a terminal diagnosis, access should be immediate and not days away. No patient should be forced to wait, suffer, or navigate the bureaucracy of receiving a 329 medical cannabis card. I asked the committee to consider the proposed amendment to allow for instant access only to the terminally ill and to patients over 65 with chronic conditions, the same way that a patient can receive a prescription for medications like Tylenol with codeine. A physician's qualification would still be required. Medical cannabis cards can be delayed 2 to 7 days currently from the Department of Health. And so we believe this amendment would greatly help with this law. I respectfully urge the committee to pass HB 1542 with amendments. Thank you for your time.
Thank you. Also on Zoom, I believe we have Akamai Cannabis Consulting, Dr. Clifton Otto.
Good morning, Chair, Vice Chair, members of the committee. Dr. Clifton Otto offering comments. Thank you for the opportunity to testify on this measure. You have my written testimony that I'd just like to briefly summarize. This is a very important bill because it gets to the heart of why we even have medical cannabis program, which is to allow the compassionate medical use of a botanical drug substance by those who are suffering with debilitating medical conditions. The problem is that despite the authority that states hold over the intrastate practice of medicine, medical cannabis patients and dispensaries must violate federal law to participate. Changing shall to may is not going to fix this problem. We need solutions like the one offered in my written testimony to reharmonize the state and federal regulation of cannabis in Hawaii so that patients can have access to commercially available medical cannabis products that do not put healthcare facilities at risk of also violating federal law. Honestly, these solutions should be coming from the Office of the Attorney General. Luckily, I believe we have the Deputy Attorney General for the Office of Medical Cannabis Control and Regulation here today. So let's figure out how to make this bill fulfill its purpose. Thank you for considering my testimony, and I will be available for any questions. Aloha.
Thank you. Healthcare Association of Hawaii, Paige Choi on Zoom.
Thank you so much, chairs, vice chairs, for the opportunity to provide some comments on our testimony. We are opposed to this measure. We are not opposed based on, we do feel like patients should have access to compassionate care. But our facilities, our members are very concerned about the potential consequences of passing this measure. I want to note that this measure is not just about hospitals, it's about all inpatient settings. So that also includes our skilled nursing facilities. I would say that it's likely almost 100% of residents in our skilled nursing facilities are Medicaid or Medicare recipients. So it's extremely important for those facilities, along with our hospitals and our hospices, to comply with federal law. We understand that there are purported safeguards in the bill. Those safeguards are not, I think, strong enough to protect our members from potential federal action if they do allow the use of cannabis in their facilities. And we also have some clinical concerns, right? When you go into a hospital, you are not allowed to bring in your medications. The medications that you use are highly regulated isn't the right word, but essentially, right, we know exactly what patients are on. And so if there is an alternate substance that's being used and there's a clinical outcome that's negative, that puts our clinicians in a really difficult position where they're having a hard time with their medication management. So I do want to, again, really emphasize that we understand that patients should have access to compassionate care, but we do remain opposed. We do not feel as if the safeguards in this bill are strong enough to protect our members from potential federal action. So thank you, and I'm available for questions.
Thank you. Let's see, on Zoom, Marijuana Policy Project, Karen O'Keefe.
Aloha, I'm Karen O'Keefe, Director of State Policies at the nonprofit Marijuana Policy Project. We are grateful to the chair for proposing this legislation to allow terminally ill patients and Kapuna to use medical cannabis in healthcare facilities. Patients do not have to give up a natural medicine that they depend on to manage their symptoms when they need care in a facility. As others have noted, including in written testimony, California passed a similar law in 2022, and it's been implemented, and we have not heard of any federal law issues. While we strongly support the intent of this bill, there are a couple of provisions where we're concerned that it actually may require facilities to ban conduct that they currently allow, and we'd urge those to be amended. First, we're concerned that HB 1542 prohibits acute care hospitals from allowing non-terminal patients from using medical cannabis in any form. We strongly urge you to revise this so it simply wouldn't require hospitals to permit medical cannabis except when intended to. Second, the bill requires healthcare facilities, including nursing homes, to ban cannabis vaporization and smoking. Under Hawaii's smoke-free law, there are exceptions for nursing home rooms if the room's residents requested a smoking room. And unlike tobacco, smoked and vaporized cannabis has medical benefits. Inhalation allows for precise dosage, titration, and immediate relief, which is crucial to relief. Nursing homes should be allowed to, if they wish to, allow cannabis smoking and vaporization in private rooms. Thank you.
Thank you. Drug Policy Forum of Hawaii. On Zoom.
Aloha Chair, Vice Chair, members, Nikos Leverins with Drug Policy Forum of Hawaii. We strongly support this bill and we're grateful to the Chair for introducing this in alignment with Ryan's Law in California largely. However, we do think that medical cannabis should not be subject to more severe restrictions than smoked tobacco in healthcare facilities, given the relative lack of therapeutic benefit of smoked tobacco for those who are terminally ill or living with chronic diseases. In short, we believe that the bill should be amended so that cannabis is not treated more restrictively than smoked tobacco, and we're hopeful that you'll be able to take this amendment. We also, will note that California's law has operated quite well since it was implemented, and that if this is turned into a permissive bill, as recommended by Mr. Goff, with the expectations that he provide education to providers, then it will be an effective nullity, especially given the Department of Health's record in not providing science-based information to existing medical cannabis patients. Mahalo for the opportunity to provide testimony.
Thank you. Robert Bentz on Zoom.
Aloha, Chair. This is Robert Bentz. I might be the only one that has actually been in hospitals with this exact same problem, so I mahalo you for introducing this bill. I would like to echo the concerns of MPP and the Drug Policy Forum, and I offered written amendments to please include number 3 under patients, at least for those of us that are severely disabled and without the cannabis, we would die. I've had many doctors tell me that cannabis is the only thing that's treating my seizures, and the Stanford seizure specialist told me that the hardest problem with cannabis is staying consistent. So if I had to go into a hospital and stop my cannabis, I would have a seizure. I would have more severe disability than I already have. I had to learn how to walk and talk and swallow and everything again after a birth defect caused a brain surgery. I was in a rehabilitation hospital in California with several seniors, but there are those of us that are under age 65 that if we had to stop it, we would die. So if you could please consider my amendments. Also, seeing the testimony and concern about the federal illegality, there is already a law passed. I emailed this to you last night. I would offer the following amendment to please include patients in a state-approved study in compliance with the Medical Marijuana and Cannabidiol Research Expansion Act, H.R. 8454, Public Law 117-215, signed into law December 2nd, 2002 by President Biden. It streamlines the DEA.
Thank you, Mr. Benz. We have your written testimony, so we have that. So thank you.
This would streamline the DEA process so it very important, and I agree that if you change it to may and shall, it's a worthless bill. So
Thank you.
please let us work with the federal authorities under current federal law that allows it.
Thank you very much for your testimony. Let's see, we have written testimony from 3 other individuals offering support. Anyone I missed wishing to testify on House Bill 1542? If not, questions, members? See, I do have a question for the Healthcare Association, page Choi on Zoom. I know in your written testimony, you expressed opposition to the bill. I'm just wondering if we adopted the sorry, is she on? Okay. I just wondered if we accept the proposal to change shall to may, would that alleviate your concerns or opposition?
I think it would alleviate.
I'm sorry, go ahead.
Sorry.
Thank you.
Thank you. I think it would alleviate a lot of our concerns. I would note, right, there's been a lot of discussion about the potential reclassification. And so the suggestion to have more of a partnership with Department of Health, in particular to do an education campaign, especially if cannabis is reclassified, I think is one that we would really appreciate. Clearly, this is an important issue, and I think it's one that our providers would appreciate. I think a formal partnership on education with our practitioners, with our clinicians on. So if there was a change to permissive, I think some requirements about those partnerships for education would also be welcomed.
Okay, thank you very much. There being no other questions? Vice Chair, go ahead.
Paige, thanks for being here. In addition to the chair's question, we had a letter from Big Island Substance Abuse Council regarding exempting drug treatment within hospitals, but it does not explicitly exclude residential treatment programs. Could you expand a little bit on that?
We do not represent the residential treatment programs, so I can take a look at that letter and contact the appropriate folks at our hospitals, see if they have any insights to address that concern, and I can get back to the committee.
Great, thanks, Paige.
Yeah.
Thank you. If there aren't any other questions, let's move on to the next bill on the agenda, which is House Bill 1573, requiring electronic smoking devices and e-liquid manufacturers to certify to the Department of the Attorney General that the manufacturer received a federal marketing granted order from the FDA. First up, we have the Attorney General.
Good morning, Chair, Vice Chair, members of the committee. My name is Chelsea Okamoto. I am a Deputy Attorney General and Unit Supervisor for the Tobacco Enforcement Unit. Thank you for the opportunity to testify, and thank you to Chair for introducing and leading this bill, and for members of this committee who've also co-sponsored this bill. Our department is in strong support of this bill. The vaping industry has intentionally targeted our youth and saturated the market with highly attractive products. The Tobacco Control Act granted the FDA power to regulate these e-cigarettes, and as of today, the FDA has only authorized 39 e-cigarette products for marketing and sale in the United States. The FDA has clearly stated that these 39 products are the only products that may be lawfully sold in the United States, yet we still see a number of these unauthorized products on our shelves. Over the last year, our department has made an active effort to educate retailers and distributors about the list of these authorized FDA products. We've mailed out hundreds of letters to retail permit holders and tobacco licensees, including updating them whenever there's a change to this list by the FDA. And we've also updated our website with these retailer resources. So we've laid this groundwork to educate and raise awareness. We've essentially set the table, and now we're asking the legislature to pass this bill to give the department the tools needed to enforce. So this bill creates a directory. It runs parallel to and in lockstep with the FDA's authorized list. It creates a certification process that manufacturers need to abide by to participate in Hawaii's marketplace. It gives the department inspection powers to enforce the directory and rulemaking abilities, and penalties for manufacturers that don't comply with this process, and penalties for parties that sell the products not listed in the directory. These penalties will go back to help fund the enforcement of this directory. So we ask you to pass this bill, and thank you. We're available for questions.
Thank you. State Office of Information Practices. Offering comments. If I may, for the, it's out of order, but for the Deputy Attorney General, just wanted you to look at, if you can, the OIP suggestion that we delete subsection D on the top of page 3. So could you take a look at that?
So Office of Information Practice did reach out to us to notify, and it was their testimony also submitted in SB 1525 last year. We'll defer to the Office of Information Practice since this is their area of expertise.
Okay, thank you very much. Department of Health?
Good morning, Lola Irvin for the Department of Health. Thank you, Chair Takayama and Chair Martin and members of the committee. So the Department of Health would like our youth to have just the best health possible. And we work on education, and we know that our youth, our young children are using e-cigarettes. And so we're working on education. We actually have cessation programs for them called My Life, My Quit. We also know that young adults are using them. So we have the Hawaii Tobacco Quit Line, which is also now providing services for those who are using e-cigarettes. And we have a new campaign out now to especially reach out to young adults. That is not enough. So as the Deputy Attorney General mentioned, there are 39 products that have received the marketed granting orders from the FDA. There are over 6,800 of these e-cigarettes still out in the market. And what we do not have in Hawaii is the enforcement ability. And so we're state, we're not the federal government. And so we can't enforce their laws. And so the problem we have is, while we know that there are only 39 products that receive federal marketing orders, as a state, we can't confiscate them. So the Department of Health can't say, oh my goodness, these aren't allowed. You need to take them off the shelf. And so to provide the state Attorney General's office with the authority to then fully investigate and also then enforce the laws is what we need. Because on the balance, we have the education, we have the quit support. 22% of our young adults age 18 to 24 say they currently use e-cigarettes. 25% of the 25 to 34-year-olds say they use. So those are the young people that started in high school. They're still using it out of their high. We're also getting requests from elementary schools. So we really need help to get these products off the market. And so we appreciate the Attorney General's support behind HB 1573. Thank you so much for introducing this bill.
Thank you. Dr. Jack Lewin.
We stand in strong support of chairs, vice chairs. We stand in strong support. Stand by our testimony. Thank
you. Hawaii Public Health Institute, Kevin Ramirez.
Good morning, chairs, vice chairs, and members of both committees. My name is Kevin Ramirez. I'm the program manager for the Coalition for Tobacco-Free Hawaii, which is a program of the Hawaii Public Health Institute. I want to thank you for hearing this bill and the opportunity to testify. I'm here to testify in support of HB 1573 relating to health. So in the 9 years that I've been working with the coalition, part of my role and responsibility has been coordinating the 808 No Vape campaign. And the 808 No Vape campaign is providing vaping prevention education to schools across the state. And I have spoken to thousands of students. Most recently, in the last 3 years, all of those students have been majority elementary school students. So what I can tell you is the vaping problem still persists in our communities and in our schools. What I can also tell you is that the vast majority of e-cigarette products that are driving the vaping problems in our communities and in our schools are unauthorized. And what unauthorized basically means is illegal. The Federal Food and Drug Administration is the agency tasked with regulating tobacco products, and they only have 39 products on their authorized list. And one of the reasons they only have 39 products on that list is because they have rather stringent criteria when they evaluate e-cigarette products. What they're really looking for is if an e-cigarette product is going to be a benefit to public health. And what that really entails is this product going to be something that an adult smoker would switch to using so they can quit smoking combustible cigarettes? The other half of that criteria is this e-cigarette going to appeal to youth? And if it appeals to youth, it doesn't make the list. So HB 1573 will sweep our state market from all these unauthorized products that are driving the youth vaping epidemic and empower our state attorney general's office to take enforcement actions. So thanks again for the opportunity to provide testimony in support of HB 1573. Mahalo.
Thank you. Let's see, we have Lanai Community Health Center expressing support. Hawaii Smokers Alliance in opposition. In addition, we have written testimony from, let's see, a dozen individuals in support and 3 in opposition. Anyone I missed wishing to testify on this bill? If not, members, questions?
For the Department of Health. So I see that this bill would give you folks more, or give you enforcement tools that you don't have. Obviously that takes humans, people to go and do it. Would you be paying for that staff with the fees collected, or how would you actually execute this, or do you already have the capacity?
Chair Martin, that is an excellent question, and we have exactly the right person and the partner in the room. We're actually working together. So may I have your permission to call up Deputy AG Chelsea Okamura? Thank you. Because we're actually working together on that issue.
Thanks, Lola. Thanks, Chair Martin, for the question. So the Department of Attorney General is going to be tasked with the enforcement of this directory. So we would manage the directory, post the directory, and we would also be the ones tasked with also enforcing it. We do already have tobacco inspectors who are already out in every tobacco retail location making inspections. And so they're already there doing that function. And so to put this directory in their hands as a tool, it makes it very easy for them to start doing enforcement in this new space of e-cigarette phase. I've spoken to our investigations division, and they're willing to take this on without having any appropriation from the legislature. That being said, the way the bill is structured, there are civil penalties if the manufacturers do not follow the process of certifying their products, and there are also civil penalties when someone is caught selling these products, and those will go back to fund the functions of enforcing this directory. So hopefully it's self-sustaining. We haven't tried it yet, so hopefully next year we'll have a better understanding of what it costs to do this. But right now we do already have people in place to try to take this on.
And then if I may add to that, to the partnership, through our Attorney General's office, there was a settlement with Altria, the 33% owner of Juul. And so the Department of Health is responsible for those funds. And the Tobacco Enforcement Unit, besides being here and enforcing what is happening in the marketplace, they also diligently enforce tobacco master settlement agreement. And so in order to support what they're doing with the e-cigarette side of things that's happening now, we are actually have a memorandum of agreement, and we're supporting what they're doing with the e-cigarette situation and the inspections. And so I think that fund is going a long ways to get them started. And then of course, as they look at the fines and citations, hopefully then it will be something that will continue to be sustainable.
Thank you very much. Thank you, Chair.
Thank you. Any other questions? If not, let's move on. Next bill is House Bill 1704, adopting the Psychology Interjurisdictional Compact. And first up, we have Dr. Jack Lewin.
Thank you, chairs, vice chairs, members. We stand by our testimony and support. Thank you.
DCCA, Board of Psychology.
Good morning, Chair Takayama and Chair Martin. For not identifying the committee and yourself in the heading of the board's testimony, I sincerely apologize. My name is Christopher Fernandez, Executive Officer for the Board of Psychology. I'm here to offer comments on the bill on behalf of the board. The board just wanted to note that it has submitted testimony for previous iterations in other legislative sessions. They continue to be unable to identify information regarding enforcement costs related to the compact. The board would have to establish FBI background checks, so that would be working with the FBI themselves. There's certain educational requirements to join the compact, and this may limit the board's authority to determine degree requirements here in Hawaii for our own licensees. The types of doctoral degrees in psychology that we currently accept, clinical counseling and school psychology, we may be needing to accept a larger number of those types of doctoral degrees. And lastly, I think that the board has also just identified sociocultural factors that may contribute to the quality of services, and then also there may be a fiscal impact regarding license fees being received to the state. Thank you, and I'm here available for any questions.
Thank you, Mr. Fernandez. And actually, no apologies in order, because it's actually the first two bills that were a joint committee. The rest of it has been just health committee. So thank you. Hawaii State Association of Counties, Nahilani Parsons.
Aloha Chair, Vice Chair and members of the committee. Nahalani Parsons here on behalf of Hawaii State Association of Counties in strong support of this measure. Just want to thank the committee for hearing this. Our membership includes a council member from each of our 4 counties, including all of our council chairs, and we're trying to address the shortages and rural health needs of our underserved communities. So appreciate this measure. Thank you.
Thank you. Hawaii Association of Health Plans, Rachel Wilkinson.
Good morning, chairs, vice chairs, members of the committees. Rachel Wilkinson on behalf of the Hawaii Association of Health Plans in support. As you know, Hawaii continues to face a shortage of mental health professionals, particularly on the neighbor islands and in our rural communities. So we appreciate the compact's ability to increase mental health services statewide. Thank you for the opportunity to testify.
Thank you. Let's see. HGEA, Randy Pereira. In opposition. On Zoom, Aloha Care. Mike Nguyen. Not present. He's in support. Anyone I missed wishing to testify on House Bill 1704? If not, members' questions. Okay, seeing none, let's move on. Next bill, we have House Bill 1996, which would exempt from the general excise tax hearing aid purchases. And first up, we have Department of Taxation.
Good morning, Chair, Vice Chair, members of the committee. Robert Avila on behalf of DOTAX. We stand on our written testimony providing comments. To summarize, we're just requesting that the effective date of the bill be amended from July 1st, 2026 to January 1st, 2027 to provide sufficient time for form and instruction changes and to inform taxpayers of the new change. Here to answer any questions.
Okay, thank you. Disability and Communication Access Board in support. Tom Yamachika, Tax Foundation of Hawaii on Zoom.
Thank you, chairs, members of the committee. This is Tom Yamachika from Tax Foundation of Hawaii. We submitted written testimony which basically says we are wondering why hearing aids are being singled out for special treatment while over-the-counter ocular or dental health materials are not currently exempt and would continue to be non-exempt under this bill. That's the only anomaly I wanted to point out. Thank you very much for the opportunity, and I'll be available for questions.
Thank you. Also on Zoom, Peter Fritz.
Thank you. I've been unmuted. My name is Peter Fritz. I'm an individual with disabilities and a person that also uses hearing aids. In terms of why it addresses hearing aids is because many years ago, I paid $127 of GE tax when I purchased hearing aids, and I drafted a bill. I agree with the Department of Taxation suggestions about changing the effective date. I think that it's the right way to do it. And my testimony focused also on the fact that making hearing aids more affordable will help forestall or has been shown in studies, and anybody that would like to see some of those studies, I have them in my research file. Dementia, it also reduces trips to the emergency room because people aren't surprised when somebody comes up behind them and can hear them. And so I would respectfully ask that the committee move this forward. Thank you for the opportunity to testify.
Thank you, Mr. Fritz. Let's see, we have 4 individuals submitting testimony in written form in support. Anyone else wishing to testify on House Bill 1996? If not, members, any questions? Okay, seeing or hearing none, let's move on to House Bill 1547, which would provide a tax credit for qualified taxpayer insurers that offer one or more federally qualified health savings account eligible health plans. And first up, we have Department of Taxation.
Good morning, Chair, Vice Chair, members of the committee. This is Robert Avila on behalf of DOTAX. We stand on our written testimony providing comments. To summarize them, we recommend that the bill be amended to include a 5-year time limit to claim any credit carry forward. As credits claimed further from the year in which they are incurred, the expenses are incurred, are more difficult to verify. We also note that it is administratively difficult for us to administer aggregate caps. So we would request that the certification for any tax credits be handled by a third party. The rest of our comments really relate to some of the definitions in the bill that we think could provide a little more clarity and allow us to make the administration a bit easier. For example, terms like rural, terms like written in, a policy being written in Hawaii. Having more clarity around what these terms precisely mean would allow us to better administer this bill. And then finally, DOTAX would like to note that we would have trouble enforcing the bill's health savings account matching provision, since we would need to determine when the amount of a policyholder's first-time contribution, and then compare that to the qualified taxpayer's claimed tax credit amount. And then, as with the other bill, we would just recommend that so that the effective date is moved for taxable years beginning after December 31st, 2026. That would allow us to prepare forms, make system changes, necessary rules, and inform taxpayers of the new tax code. Thank you. Here to answer any questions.
Thank you very much. State Department of Labor and Industrial Relations submitted testimony offering comments. On Zoom, Tom Yamatika, Tax Foundation of Hawaii.
Thank you, Chair, Vice Chairs, members of the committees. Tom Yamachika from Tax Foundation. We are primarily concerned because there are blanks throughout the bill that contain important information. We would strongly urge the committee to fill these in before moving the bill forward. We believe that's what's required under Mason's manual. So we look forward to continuing the conversation once the blanks are filled in. Thank you, and we'd be happy to answer any questions.
Thank you. Hawaii Medical
Aloha chairs, members of the committee, members with Ignacio, Hawaii Medical Association. We stand on our written testimony and support with comments available for questions. Thank you.
Thank you very much. Let's see, we also have written testimony and support from Dr. Robert Thomas Carlisle. Anyone I missed? Anyone else wishing to testify on House Bill 1547? If not, members' questions. Seeing none, let's move on to the final bill on the agenda, which House Bill 1563, which would repeal the existing law that preempts local ordinances or regulations that regulate the sale of cigarettes and other tobacco products. First up, the Office of the Attorney General.
Aloha again, chairs, vice chairs, and members of the committee. Chelsea Okamoto again, Deputy Attorney General and Unit Supervisor of the Tobacco Enforcement Unit. Thank you for the opportunity to testify on this bill. You have our written testimony. Our department's in support of this bill. Chapter 328J, Section 11.5. It's a statute that currently preempts and prevents counties from enacting ordinances or regulations associated with tobacco sales, including the sales of e-cigarettes. And so the department supports restoring this authority to them to adopt more stringent tobacco control measures and to regulate tobacco products. In our testimony, we've raised a concern that the bill may inadvertently limit counties who already have the existing authority to regulate smoking. So we suggest adopting the approach as in HB 1117, which is just to repeal 328J 11.5 in its entirety, or alternatively, we outline to amend page 6, lines 13 and 19 to add wording to explicitly allow them to have the authority to regulate smoking. So we ask the committee to pass this bill with our recommended revisions, and thank you for the opportunity to testify. We're here if you have questions.
Thank you. Department of Health.
Good morning, Lila Irvin. Good morning, Lila Irvin with the Department of Health. Thank you, Chairs Takayama and Martin, and thank you, members of the committee. Thank you very much for introducing HB 1563. This is in line with the Department of Health's value of engaging with the community. And to do so, we do outreach, we provide funding for coalition building, we provide education, training, and unfortunately, with the introduction of Act 206, Part 2, and the insertion of 328J 11.5, wow, we have engaged communities and we provided them with data and they know more about their communities and what's happening. We've taken away the ability for them to pass more restrictive laws and regulations at the county level. And prior to 2018, the counties were very innovative in addressing the needs. And so we do have in our testimony a list of the things that they've done, like smoke-free cars when KPs are in the car, smoke-free beaches. Even our smoke-free laws started at the county level before it became state level law. And so the repeal of 328J 11.5 would then return the county's right to be able to protect their KP. So thank you for the opportunity to provide testimony.
Thank you very much. Dr. Jack Lewin.
Good morning again, chairs, vice chairs, and committee members. We support and echo the comments we've just heard from the AG and from the Department of Health. Thank you.
Thank you. Let's see, we have statements of support from Hawaii County Council Member Jen Kagiwara, Hawaii Substance Abuse Coalition, Hawaii COPD Coalition. Sorry. Hawaii Public Health Institute, Keith Ramirez.
Aloha and good morning again, chairs, vice chairs, and members of both committees. Kevin Ramirez here, Program Manager for the Coalition for Tobacco-Free Hawaii with the Hawaii Public Health Institute. Thanks again for hearing this measure. and providing the opportunity to testify. I'm here to testify in strong support for HB 1563 relating to tobacco products. Historically, effective tobacco prevention and control laws that protect our community from secondhand smoke, protect our youth from tobacco products have started at the local level. This was certainly the case in the late 1990s when our local county coalitions were passing smoke-free air laws, and then the state adopted that some years later. A more recent example is 2013 when Hawaii County passed a law raising the age of sale of tobacco products from 18 to 21. And in 2013, they were only the 4th jurisdiction in the country to do so. 2 years later, the state of Hawaii adopted that as a state law and raised the age of sale from 18 to 21. And then in 2020, that law was passed at the federal level. So you can see that it's important that local jurisdictions have the authority to act quicker to protect their communities. And the tobacco industry is well aware of this, and this is why that they've been trying to take county authority away from the counties nationwide. And in 2018, unfortunately, that happened here in the state of Hawaii. So for the last 8 years, we've been trying to restore county authority to regulate tobacco products at the point of sale, and the counties want the authority back. In fact, in 2023 and 2024, despite the fact that they don't have the authority to do so, Honolulu County, Hawaii County, and Maui County all passed ordinances to end the sale of flavored tobacco products that unfortunately could not take effect until county authority is restored. So thanks again for the opportunity to testify in strong support of this measure. Mahalo.
Thank you. On Zoom, Coalition for Tobacco-Free Hawaii Youth Council, Luke Itamura.
Aloha Chair Takayama, Chair Martin, and members of the committee. Sorry about the jump scare. I know you guys were expecting a youth, but unfortunately he had to run off to class today. But my name is Saya Shibata, and I'm the youth coordinator speaking on behalf of the Coalition for Tobacco-Free Hawaii Youth Council in strong support of HB 1563. For years, the Youth Council has worked alongside community advocates to end the sale of flavored tobacco across the state. Because of their work, the City and County of Honolulu, the County of Hawaii, and the County of Maui have passed bills to end flavored tobacco sales in their communities. By restoring county authority, these county-passed laws can be fully implemented and enforced, allowing counties to better protect their communities. As a youth coordinator, one of my responsibilities is educating students about the dangers of tobacco use. In every classroom, I first start off by asking them, is vaping a problem in your school or community? Nearly 90% of students typically raise their hands. This shows that youth e-cigarette use remains a serious issue and that stronger tobacco regulation and control are needed to protect our keiki. With federal tobacco funding eliminated, restoring county authority allows communities to respond quickly to emerging threats and prevent harm before it spreads. Please pass HB 1563. Thank you for the opportunity to testify.
Thank you. Also on Zoom, American Lung Association, Pedro Haro. Not present. Let's see, American Heart Association.
Good morning, Chair, Vice Chairs, members of the committee. On behalf of the American Heart Association, we stand in strong support of this measure. Based on a lot of the comments you heard from DOH and Hi-Fi, I think this is a policy that takes us in the right direction of preventing one of the most preventable forms of death in Hawaii, right? Preventable causes of death. So, for those reasons, we stand in strong support and are available for any questions. Thank you.
Thank you. Let's see, we have written testimony also from both the Hawaii Smokers Alliance and Cigar Association in opposition. I'll note that we have 11 other organizations in support. 50 plus individuals have submitted written testimony in support. I might note that one of them said they support regulating Tabasco. I assume that was a typographical error. And we have 7 in opposition. Anyone I missed who wishes to testify on House Bill 1563? Okay, seeing none. Members, any questions? No questions? Oh, okay, well, I believe we can now move on to decision making. Thank you all for your testimony. Members, I'll ask us to okay. Okay, sorry, just bear with us for a minute while we get ready for our votes. So first up, we have House Bill 1969 relating to colorectal cancer. And this is a jointly referred bill. I suggest we move this bill forward as a House draft, deleting the FAQ section of the bill, which made reference to ACA FAQs that may be updated regularly. So testimony we received suggested deleting that. We would still have the federal task force, which fairly clearly specifies colorectal screening standards. So we'll delete the FAQ section of the bill, also add an effective date, and add in report language, which suggests funding amount of $1.8 million a year and one position to administer the program. That's my recommendation. Members, any questions, comments, or concerns? If not, Vice Chair for the vote.
Thank you, Chair. Members, voting on House Bill 1969, Chair's recommendation is to pass with amendments. Chair votes aye, Vice Chair votes aye. Member Almont.
Aye.
Member Hartsfield.
Aye.
Member Martin.
Aye.
Member Olds.
Aye.
Member Takanouchi.
Aye.
Member Alcos.
Aye.
Member Garcia.
Aye.
Chair, your recommendation is adopted.
Thank you. For Human Services.
Human Services, same recommendation. Are there any questions or concerns? And Vice Chair for the vote?
Thank you, Chair. Voting HB 1969, Chair's recommendation is to pass with amendments. Any members voting no? Any reservations? Chair, your recommendation is adopted.
Thank you. Next bill up is House Bill 1965 relating to primary care providers. First up, I'd like to thank the Vice Chair of the Health Committee for introducing this bill after working with health providers on the Big Island. I believe it is a very important measure, one of the most important we'll consider this session. And I think it would move our health system in the right direction forward in keeping our primary care providers in business, especially in rural areas and on both on Oahu and on the neighbor islands. However, I believe that the State Insurance Commissioner raised some substantive questions about some details of the bill that I believe require more work on our behalf. I was particularly moved by the passionate support for this bill by the state office by SHPTA, Dr. Jack Lewin. And so I'm going to suggest that we form a working group under the terms of this bill. And the working group would be led by Dr. Jack Lewin. And it would be tasked with considering several of the points that were made in the bill. Namely, the working group should consider, number one, setting minimum percentage expenditures on primary care reimbursements by health carriers. Number two, consider the issue of downcoding and inappropriate modifications to submitted claims. Number three, consider new reporting requirements for health carriers. Number four, penalties for violations. Number five, possible creation of a primary care stabilization fund. Number six, give particular consideration for the needs of rural health area residents and providers. And finally, consider what federal approvals may be required to enact this measure. The working group would be led by the administrator of SHPTA, as I mentioned before. And the members shall consist of 5 members representing the insurance industry to be selected by the Hawaii Association of Health Plans, 5 members representing licensed healthcare professionals, 2 of whom shall be selected by the Hawaii Medical Association, 2 of whom shall be selected by the Healthcare Association of Hawaii, and 1 selected by the UH School of Medicine, JAPS. I'm sorry, members, bear with me because it's important that we specify this in the measure. In addition, 5 members representing consumers of healthcare or employers, 2 of whom shall be selected by the Board of Trustees of the Hawaii Employer Union Health Benefits Trust Fund, 1 of whom shall be a consumer selected by the Statewide Health Coordinating Council, 1 of whom shall be selected by the Hawaii Primary Care Association, and 1 selected by Papa Ola Lokahi. Members of the working group shall elect the chair and vice chair from among themselves. Director of Health, Insurance Commissioner, and Administrator of MedQuest Division of Department of Human Services shall each appoint an ex officio advisor for the working group. Finally, working group shall submit a report of its findings and recommendations, including any proposed legislation, to the legislature no later than 20 days prior to the convening of the regular session of 2027. Those are my recommendations, as well as adding a defective date to the measure. Any questions, comments, or concerns? Vice Chair?
Thank you, Chair. First of all, thank you. I appreciate the wisdom of the direction you're taking this. I think oftentimes we're eager and swinging for the fences, but I also recognize there's a lot of substantive adjustments that have to happen. And I think clearing that through the working group is the best course of action. And I also do appreciate Dr. Lewin leading that working group. And I just wanna note something he mentioned in testimony, which is we need to find a way to do it together. So thank you, Chair, for that recommendation.
Thank you very much. Any other comments?
Chair, I'd just like to echo the comments by Vice Chair and also to all the testifiers today. This is the type of discussions we need in order to make good law and to help better how we do things in Hawaii. And so I'm just proud to be part of that process, and mahalo to everyone and the good decision that I believe is being made today.
Thank you very much. And also a lesson on you shouldn't leave the room before we have decision making. Also, well, any other questions? If not, Vice Chair for the vote.
On members on HB 1965, it's a recommendation of the chair to pass with amendments. Seeing all members present, any reservations? Any no's? Chair, your recommendation is adopted.
And for the Human Services and Homelessness Committee, also HB 1965, same recommendations. Are there any comments or questions? Seeing none, Vice Chair for the vote.
When HB 1965, Chair's recommendation is to pass with amendments. Any members voting no? Reservations? Chair, your recommendation is adopted.
Thank you. Let's move on to House Bill 1804 regarding Long-Term Financing Advisory Commission. I'd like to move this bill forward. Legislative Reference Bureau in its testimony said it really lacked the expertise in certain areas that would be helpful to the commission. So my suggestion is that we replace references to LRB with Office of the Legislative Auditor instead, because I believe that office has the resources and expertise in actuarial studies and this particular field of expertise. Also like to add the recommendation from Healthcare Association that we add a representative from the long-term care providers to the commission. Finally, I'd like to delete reference to the $100,000 appropriation and put that in the committee report instead. And finally, add a effective date. Members, any questions, comments, or concerns? Seeing none, Vice Chair.
Thank you, Chair. Members, voting on House Bill 1804, Chair's recommendation is to pass with amendments, noting all members present. Any members with reservations? Any voting no? Chair, your recommendation is adopted.
Thank you. Next bill, 1976, relating to training in dementia. I'd like to move this forward as a House draft, incorporating suggested amendments from the Office on Aging regarding start dates and content of the curriculum. Also added effective date.
And end date also? You mean switching the start date and the end date?
Well, yeah, I'm sorry. Start date and end date for the training sessions. Yeah, thank you, Chair. Questions, comments, or concerns? Vice Chair for the vote.
Thank you, Chair. Members, voting on House Bill 1976. 1976.
It's a long morning, yeah.
Chair's recommendation is to pass with amendments. Members, noting all members present. Any members voting with reservation? Any voting no? Chair, your recommendation is adopted.
Thank you. This next bill, House Bill 1530, is a particularly sensitive one, and I appreciate hearing from the community. However, the Attorney General raised some substantive concerns about the legality of the bill. I just want to note that the intended those who are intended to benefit from these. We read about horrific stories in healthcare and child abuse in certain families, and we demand that the adults be punished to the full extent of the law, but we never really hear much about the victims, the child victims. And we know that they're scarred, they're damaged, and they need help of programs such as this. I mean, the nature of the programs is to put them in an environment where they see families that are loving and parents who care for their children and express that love for them. And that's something they had never seen in their lives before. And so I fully appreciate the merits of the program, which is all the more disappointing that the Department of Health and Catholic Charities failed to provide any kind of advance notice to the community, or continuing to provide more adequate, I think, interaction with the community, which I think is much needed for programs such as this. So with that, I'm gonna defer this. So let's move on to House Bill 1541, exempting certain positions in Department of Health for the State Hospital and Developmental Disabled Division. I'd like to move this forward with a defective date. Questions, comments? Vice Chair.
Thank you, Chair. Members, voting on House Bill 1541, Chair's recommendation is to pass with amendments, noting all members present. Any members voting with reservation?
Reservations.
Reservations.
Thank you, Ms.
Reservations.
Amando. Thank you, Mr. Alcos. Thank you, Mr. Garcia. Thank you, Mr. Olds. Any other members? Any members voting no? Chair, your recommendation is adopted.
Thank you. Next bill is House Bill 1542, relating to compassionate access to medical cannabis. My original inclination was to defer this bill, but I think it bears further consideration, so I'd like to move the bill forward as a House draft, incorporating the suggestions from the AG and others that we change the word shall to may in the text of the bill. Also exempt residential treatment centers. And finally, add an effective date. Members, any questions or comments or concerns? Seeing none, Vice Chair.
Thank you, Chair. Members voting on House Bill 1542. Chair's recommendation is to pass with amendments, noting all members present. Any members with reservations? Any members voting no? Chair, your recommendation is adopted.
Thank you. House Bill 1573 relating to electronic smoking devices. I'd like to move this forward as a House draft, incorporating a suggestion from Office of Information Practices, which would delete subsection D on the top of page 3 in the bill, which related to non-disclosure requirements. Secondly, on page 7, because the bill really, as it exists, really doesn't address violations after the 4th violation, I'd like to add the word 4th and subsequent violations. Finally, add a defective date. Questions, comments?
Comment.
Yes, please.
I really appreciate the testimony because I learned that this bill is even better than I thought it was. I'm very excited about it.
Well, the author really knew what he was doing, I guess. Vice Chair for the vote.
Thank you, Chair. Members voting on House Bill 1573. Chair's recommendation is to pass with amendments, noting all members present. Any reservations? Any voting no? Chair, your recommendation is adopted.
Thank you. House Bill 1704 relating to the psychology interjurisdictional compact. I'd like to move this forward as a House draft with technical and technical amendments. Also like to defect the date and noting for in the report language for future committees consideration that the DCCA's DCCA's Board of Psychology noted in its testimony that it had not yet reviewed the bill, but raised possible consideration of requirements that should be examined for out-of-state psychologists. So members, any questions, comments, or concerns? If not, Vice Chair.
Thank you, Chair. Members voting on House Bill 1704. Chair's recommendation is to pass with amendments, noting all members present. Any members voting with reservations?
Reservations.
Thank you, Mr. Garcia. Any members voting no? Chair, your recommendation is adopted.
Thank you. House Bill 1996 relating to hearing aids. I'd like to move this forward as a House draft and actually remove the sunset date, which is actually a 2-year sunset date. I'll just remove this totally. Also add a defective date. I guess that's it. Questions, comments, concerns? If not, Vice Chair.
Thank you, Chair. Members voting on House Bill 1996. Chair's recommendation is to pass with amendments, noting all members present. Any members voting with reservations? Any members voting no? Chair, your recommendation is adopted.
Thank you. Next bill, House Bill 1547 relating to health savings accounts. You know, I commend the author of this bill because I think the bill has great intentions, which is to help rural area residents in keeping or obtaining health insurance. But it's clear from the testimony that it needs more work. I know that there's a Senate companion bill which is up for consideration in the Senate, and should it pass over, I think we can, give it further consideration. But for now, I think we should defer this bill. Final bill on the agenda, House Bill 1563 relating to tobacco products and preempting local ordinances. I'd like to move this bill forward. I'd like to incorporate the Attorney General's amendment, which is to delete Section 2, which is the section relating to statewide concern, delete that entirely. Also delete section 4, which is the so-called savings clause, which is really not necessary and extraneous. And finally, add a effective date. Members, any questions or comments or concerns?
Did you want to change that language for smoking or sale? Or when we brought up, she brought up that maybe they already have the ability to regulate smoking.
Oh, yeah, no, I think that
Or is that
if you exempt,
is that
yeah,
one of
I
the
mean,
sections that was deleted?
if you delete the section 2, then that takes care of their concern, so
Okay,
that was their.
I didn't know where that section was.
Yes, no, so
thank
that
you.
was why they. Any other comments or questions? If not, Vice Chair.
Thank you, Chair. Members voting on House Bill 1563, Chair's recommendation is to pass with amendments, noting all members present. Any members voting with reservations? Any members voting no? Chair, your recommendation is adopted.
Thank you, members, for your patience. We're adjourned.